Dr. Cowley did a great job giving you an overview of PBC. My job is to now switch gears a little bit and talk about the other cholestatic disease, which unfortunately hasn't had as much progress in the last few years, and talk about primary sclerosing cholangitis, so PSC. So we'll discuss the sort of current risk assessment and our management. These are my disclosures. We'll also review what our current management of PSC is in terms of medications, malignancy screening, and some extrahepatic symptoms. So just to recap, remember that primary sclerosing cholangitis is an autoimmune liver disease that primarily affects the medium and the larger sized bile ducts, as opposed to PBC, which affects the smaller bile ducts. The prevalence indicates how rare it is. 6 to 16 people are affected per 100,000 in North America and Europe. Predominantly affects males, so 70% male predominance, and ages 30 to 40. About 50% will present with symptoms initially, either intermittently or consistently at the time of their presentation, and another 20% will develop symptoms at some point during the course of their treatment, or during the course of their disease within 5 years. The most common coexisting autoimmune condition that goes along with PSC is inflammatory bowel disease, so ulcerative colitis being more common than Crohn's or indeterminate colitis. It's a very slowly progressive disease, so like cholestatic diseases often are, it can take a while to lead to the diagnosis of it. The most common test that we check to sort of monitor for disease activity is liver biochemistry, so the alkaline phosphatase. But we know that the alkaline phosphatase levels do fluctuate significantly during the course of the disease and doesn't really plot with the ongoing progressive nature of the disease. So instead, what we have found is using fibrosis markers and serum fibrosis markers, in particular the enhanced liver fibrosis, has shown better correlation when we are looking at other elastography measurements like transient elastography. So fibrosis markers probably a better marker of the progression of disease more so than the alkaline phosphatase is. We also know that there's variable levels of IBD activity. Oftentimes when the disease is early, the IBD activity tends to be a little bit more pronounced. As the disease becomes more severe and more progressive, the IBD activity tends to quiet down. There's likely a significant interplay as well between the gut microbiome and biliary inflammation. And we see that there's some biomarkers that are associated with PSC prognosis and others that exert a pathogenic effect. And some of the microbiome biomarkers that have exert a pathogenic effect might persist after transplant and may play a role in the risk of recurrent PSC after transplant. And then lastly, we are always monitoring our patients for specific clinical events. And these are important ones that we often will discuss with our patients. So the risk of bacterial cholangitis, which often happens when there's larger ducts involved, the risk of cancer, including both cholangiocarcinoma and colorectal cancer, and lastly, the risk of progressive liver disease with cirrhosis and the decompensation events that can occur with end-stage liver disease. Unfortunately, risk assessment in PSC remains quite a challenge because clinical complications like malignancy and severe biliary strictures can develop even in early stage disease. So we see it before there's cirrhosis and before there is advanced fibrosis. But we do know that it's important in terms of assessing these risks early and assessing it with our patients continuously when we're seeing them in our practice, because it helps us prepare our patients for what is to come, and it could be clinically beneficial as well. So what tools do we currently have? These are non-serum tools, so non-blood-based tools that we can use to assess prognosis in PSC. Liver biopsy, we know, is not recommended. So histology in PSC, we know, is hampered based on sampling variability, based on location of where the strictures might be and the extent of cholestasis. There's a lot of variability. So it is not recommended in clinical practice, and really the role of liver biopsy is purely in terms of clinical trials right now. Liver stiffness measurements with transient elastography or MR elastography do correlate well with progression of liver disease and should be assessed on a periodic nature in patients with PSC. And if these tools are not available, using the enhanced liver fibrosis score, like I mentioned earlier, can also correlate well with the progression of their disease. The radiographic tools that we have include MRI and MRCP. And with itself, while it's helpful to determine whether or not there's new larger duct strictures that are developing or whether or not there's signs of portal hypertension, liver dysmorphy, you can kind of, in a subjective eye or kind of looking at the scans yourself, see if there's been more progression, but there are objective measurements that are radiologists have used, namely the Anali score, to sort of quantitate if there is significant intrahepatic ductal dilation, if there is dysmorphy, if there is portal hypertension. And using that with liver stiffness measurements does actually correlate well with prognosis. And then lastly, the MRCP Plus, which is a newer tool. It's an AI-generated tool that is a post-processing tool on top of MRCP. Using MRCP Plus, we do know that this correlates as well with liver stiffness measurements, with Mayo risk scores, and with other serum markers of prognostication. So it's objectable, it's reproducible. The question is, how accessible is it right now for our patients? But it is a tool that can be used to help prognosis. This is what the MRCP Plus looks like if you haven't seen one before. So it is quantitative metrics on the biliary tree. It gives you number and length of strictures, of dilation, of duct diameter. And you can use it with biomarkers, and it does correlate well with other risk stratification scores, like I mentioned. This is an example of a patient that had an MRCP Plus at baseline and at 1-year follow-up. And if you looked at other clinical parameters, there were no changes in liver stiffness measurement based on VCTE or biochemical measures, but we do see that there's some changes noted on the MRCP Plus. So kind of interesting to see whether or not it's actionable remains to be determined. So what other tools do we have? These are tools, these are other prognostic calculations that you can do with your patient in front of you in the clinic, as long as you have laboratory values in their clinical data. The revised Mayo risk score was traditionally the risk assessment tool that we used, and it was widely used for a long time, but it's been replaced now with some of the newer models. And that's mainly because it has very low utility in early stage disease, and it cannot predict reliably what long-term outcomes are. So the other models that we use, the Amsterdam-Oxford models, used primarily in those that might have overlap syndrome, and then the ones that are used traditionally for PSC itself are UK PSC and Presto. And I will do these in practice, usually once a year, every 2 years, to help see how my patients are marching along in their journey in their PSC. Are they relatively stable? Do I see that there is some progression in their disease? And these are readily accessible tools that you can do with your patients in the clinic. The one challenge with these tools is while it predicts the progression of fibrosis and the time to clinical event, including transplantation, these don't predict cholangiocarcinoma risk. So that remains one risk that we cannot reliably predict. Management of PSC. So medical management, unfortunately, there are no approved therapies for PSC. We rely on counseling our patients for symptoms and monitoring their symptoms. And we spent a lot of time talking about malignancy screening and other extrahepatic symptoms in our practice. What we do sometimes, what you see commonly used for our patients is ursodeoxycholic acid, and Dr. Cowley really nicely reiterated to us how there is clear survival benefit with UDCA and PBC that hasn't been demonstrated in PSC yet. The largest study in PSC had about 200 patients or so that were enrolled and did not meet full enrollment, so wasn't able to necessarily show that there was a significant benefit. Overall, though, we do think that the use of UDCA does improve liver biochemistries, or it can improve liver biochemistries, and that if it does improve liver biochemistries, there may be an improvement in long-term trajectory. The high doses of UDCA are not recommended because it is associated with a higher risk of death and liver transplantation and potentially higher odds of colorectal cancer and PSC-IBD. This is the study of UDCA and PSC that did not necessarily meet clinical significance because of, it was underpowered essentially to show this difference, but it did show that there was improvements in alkaline phosphatase and ALT values. And what we have subsequently seen in several studies thereafter is that there is an improved prognosis in people with PSC where liver biochemistries, and in particular the alkaline phosphatase, does normalize or improve. And that could be with or without the use of UDCA. There was other studies that have looked at the withdrawal of UDCA in people with PSC. And when you withdrew the UDCA in these patients, there was a recurrence of significant symptoms, including fatigue and pruritus, increased Mayo risk score, and increased ALP. So our guidelines now recommend that we should consider UDCA at a dose that's somewhere between 13 to 23 mg per kg per day, depending on which guideline you're looking at, in those that have persistent elevations in ALP and GGT. And we might be able to see that there is some potential improvement in their prognosis. What else is available? Well, nothing else is available. What else has been studied is ursodeoxycholic acid in PSC. So these are the results from the, or interim results from the phase 3 study were discussed at EASL in last year. So this is a side chain, shortened side chain of UDCA that improves the colohepatic circulation, and it prevents amidation. We think that there's improved bicarbonate-rich layer, and it could be more cytoprotective than UDCA is. So in this phase 3 study, there were 220 patients that were randomized 2-to-1 to receive nor-urso versus placebo. And overall outcomes that they were looking at was a decline in alkaline phosphatase and no worsening in fibrosis. So this study showed that 15% of those that received nor-urso met that primary outcome at 96 weeks compared to 4% in the placebo arm, which was promising. This study is ongoing, and there are additional results that will be presented, I think, when the study completes its 192-week enrollment period. And those that were not on urso in this study did appear to have greater benefit than those that were on urso. In general, the safety profile that was reviewed so far indicated an excellent safety profile of nor-urso, and the rates of AEs or SAEs were similar compared to the placebo arm, and it was generally well tolerated. Antibiotics have been studied for a long time in PSC, including vancomycin, metronidazole, rifampicin, minocycline. And there are pediatric colleagues I know in the audience that will know more about this than I do, but one of the most popular studied antibiotics right now in PSC IBD has been vancomycin, primarily because of the impact that we've seen in children that have PSC IBD that receive vancomycin having improvement in their IBD. So in this study in particular that looked at 280 kids that had PSC IBD that were treated with vancomycin, 70 were treated with vancomycin, and it seemed like the likelihood of endoscopic remission of their IBD was much higher. And there were improvements, I believe, in the biochemistries as well, in terms of liver biochemistries as well. So there have been several smaller case control studies that have looked at vancomycin. The Mayo group also had an RCT with vancomycin that did complete enrollment. So I think more to come to see what the effect is in PSC. In terms of ongoing trials in PSC, unfortunately, I don't think the bexotegrast is moving on into future phases with PSC, but it did look like there was stabilization in enhanced liver fibrosis with this integrin molecule and improvement in MRI parameters. But there are other promising studies that are underway, and we are looking forward to participating. We're looking forward to seeing the results of some of these studies. So alafibranor is being studied in ongoing trials in PSC. Bezafibrate is as well. CM-101 had some promising phase 2 data, and we look forward to seeing if they'll progress with phase 3 as well. In the last few minutes, I want to talk about what we do currently do with our patients. So malignancy screening. Cholangiocarcinoma screening is incredibly important. The lifetime prevalence or the lifetime incidence of cholangiocarcinoma in an individual patient is about 15 to 20%. That's a really, really high risk when you're talking to a young man that's in front of you that's 30 to 40 years old. So this is something that we have to really keep on top of in our clinic. We recommend doing MRCPs with CA19-9 annually, and we do know that regular surveillance is associated with higher 5-year survival. So there was a nice study that looked at those that had regular annual or biannual screening MRCPs compared to those that didn't, and that's likely due to earlier detection. Colorectal cancer screening, those that have PSC IBD, is recommended yearly, with colonoscopy beginning at age 15 when you're diagnosed in the pediatric population. Gallbladder carcinoma is recommended with an yearly ultrasound, and if there are polyps that are detected that are less than 8 millimeters, then to shorten that frequency to every 6 months. And then hepatocellular carcinoma screening is recommended every 6 months with cirrhosis. So with cholangiocarcinoma screening, we're getting the MRCPs. What do you do with that information? If you have a relevant stricture, meaning a stricture of the CBD or the larger hepatic ducts, it's important to follow that up with an ERCP with biopsies or brushings for Fisher cytology. Sequencing from cytology is not routinely recommended yet, although that is available at certain institutions. While it improves the sensitivity, it remains not necessarily the most specific right now, but can be added if there is concern. It's important to think about the indications for ERCP apart from whether or not there's dominant strictures and concern for cholangiocarcinoma. Oftentimes we do see that just for the diagnosis of PSC, patients are getting ERCPs, and that's not recommended and it's not needed unless there's true concern for what that dominant stricture, that larger stricture might be. So if there's new or worsening pruritus, if there's unexplained weight loss, worsening in liver biochemistries, elevated CA19-9, those are all potential indications to proceed with an ERCP. A reminder that ERCPs in our patients with PSC do carry a risk of cholangitis, so peri-procedural antibiotics are recommended. 1 to 3 days, usually at the time of the ERCP, and then 3 days following the ERCP. They also carry a risk of pancreatitis, and our advanced endoscopists, or hopefully yours, are using indomethacin or putting a PD stent to reduce that risk. And it's important to replace these plastic stents and make sure your patients aren't lost from ERCPs if they did have a stent put in. Management of extrahepatic symptoms. So I did mention earlier that about 50% of our patients with PSC have significant symptoms at the time of their diagnosis, and up to 20% more will develop it during the first 5 years of their diagnosis. The most common symptoms are pruritus and fatigue. There is a host of medications that are non-FDA approved for the management of cholestatic pruritus right now, cholesterol being one of them, and others that are being studied, including volixibat, which is being studied in a phase 2 trial for PSC-associated pruritus. And then lastly, fatigue and brain fog. This is a hard one to combat in clinic, and I don't have great tools to do this with our patients, but I will validate that their symptoms could be related to their cholestatic disease and emphasize that it's important to use pacing strategies to still be physically active. And we are fortunate enough to now have a psychologist that's part of our group, and I will refer many of these patients for therapy with her, just to, for acceptance, commitment training, for CBT as well. And I will always offer resources through a lot of our patient advocacy organizations, which I think makes a big difference for our patients. So in summary, PSC is very heterogeneous and it has variable risk of progression. The risk of decompensation or transplantation can be assessed with some clinical prognostic tools and non-invasive measures. There are no currently approved therapies for PSC, but you can consider UDCA if there's ongoing elevations in ALP and GGT values. There's many trials that are ongoing or about to start, so please consider clinical trials for your PSC patients. It's hard to sometimes fill these trials because it's a rare disease, so really think about whether or not your patients may qualify. Malignancy screening remains a cornerstone of what we're doing in our practice when we talk about our patients, and it's really important to inquire about extrahepatic symptoms, including pruritus and fatigue, when you have these patients in the office with you. Thank you so much for your attention.